My name is Michael Weiner. I'm the director of the Herbert Irving Child and Adolescent Oncology Center at the Morgan Stanley Children's Hospital and Columbia University Medical Center. I'm joined this morning by Julia Glade-Bender and Darrell Yamashiro, and we wanted to share with you some of our thoughts about our special programs at our center. In addition to caring for patients and teaching residents and fellows, there are some special components to what we do that we felt compelled to tell you about. We have wonderful programs in integrative medicine, which really is the benchmark program in the United States, where our patients and their families can take advantage of mind-body therapies, acupuncture, acupressure, and behavioral issues, nutrition counseling, and so forth. But Julia leads an enterprise called the Developmental Therapeutics Program, and we're one of only 20 programs in the United States and the only one in New York to have such designation. So I'd like Julia to tell us a little bit about the work that she's doing.
So, developmental therapeutics is really for the children for whom the standard therapies no longer work. And it's often difficult to choose that as your point of starting. But again, our goal is that unless we're curing every single child with cancer, it's not good enough. And so the Developmental Therapeutics Program was developed so that we could bring new agents to children. And if you think about it, children are really, they don't vote, they don't raise money, and so someone has to be an advocate for the children and develop the drugs for the children. And so our program not only helps in this endeavor, but also offers options for kids who have been told that standard options are no longer something that would work for them. And it's been quite an exciting endeavor. I think that children can be, if you will, victims of clinical research, but that is not at all the style of our program. We feel it's very important to offer kids options and to give them access to drugs they may have read about or heard about, but would otherwise not be available to them. And so over the course of the 6 years that we've been building, we actually have 30% more trials, and we have entered over the last year 90% more children on these trials than we have in the previous year, and we're on the same trajectory for the coming year. So we've seen tremendous growth, and it's been really very exciting, and the feedback we get from families is really excellent. Each trial has its own set of what we call eligibility criteria, who may or might not be able to take a drug safely, and so the idea is that we have a number of options that if any child came to us with interest in one of these kinds of agents, that we would be able to offer them something. And many times kids actually go on a number of trials, and we get lucky and hap upon a drug that helps them feel well and keeps their tumor in check.
Can you give us an example of a trial from the past with a new agent, a developmental or experimental agent that presently is being used to treat children who have newly diagnosed disease?
Our division really should be very proud of the work that we did with bevacizumab, Avastin, which is the blockbuster agent really for adults with colorectal cancer, breast cancer, now renal cell carcinoma, and glioblastoma multiforme adult, and also childhood brain cancer. And the reason we should be particularly proud of developing that agent is actually because my colleague, Darrell Yamashiro, did the preclinical work in the lab that helped us, and particularly me, to run the national clinical trial of this drug.
Darrell, let me ask you. Julia mentioned that this was work that you had done in your laboratory. Do you tell us about that process and how the work that you've done is now benefiting patients?
What we have focused on is to try to figure out what is unique about these childhood cancers and how to treat them. And so we've developed models of these various different tumors to try and then figure out how to target those tumor with very specific agents rather than sort of borrowing from necessarily the adults. And so that's been the process in the lab, is to look in animal models to see whether these tumors are affected by various different agents. And then, because we've had positive results, as Dr. Glade-Bender mentioned, that what we've been able to do is to take drugs like Avastin and to actually bring them to clinical trials in children.
So, in reality, work that you're doing in your laboratory and some of the other labs that we have within our center here at Columbia University is actually benefiting patients.
That's correct. So another example is the work that Dr. Ferrando is doing looking at T-cell leukemia. And what he's found is that there's a particular mutation that occurs in many of these T-cell leukemias. It's a mutation in a protein called Notch. And currently there are actually development of Notch inhibitors, and that actually is going into clinical trials in both adults and also in pediatric patients as well. So it's an example of understanding the biology and the genetics of a tumor, and then using that knowledge to then say, what are the best drugs that we can use to try and target those and potentially, hopefully, treat these patients better.
As Dr. Yamashiro just mentioned, are the relapsed leukemias. This is another very difficult disease. We appreciate that leukemia is the most common pediatric cancer, and that overall we're curing 90%. But actually, relapsed leukemia is actually a very common disease, even though it represents only 10% of the population. And so, for example, the Notch inhibitor that Darrell Yamashiro just mentioned is entering clinical trials. That one is through the Children's Oncology Group Consortium, but also we have a separate consortium, the Therapeutic Advances in Childhood Leukemia Consortium, where we run trials specifically for children who have relapsed leukemia.
Another very common pediatric cancer are brain tumors. And we have a wonderful pediatric brain tumor program, but we also have a laboratory that does research in brain tumors. Darrell, you want to tell us a little bit about the work that Dr. Lassarella is doing?
So Dr. Lassarella is focusing actually on pediatric brain tumors. And part of the work that she is doing is to try and analyze the various different genes that are turned on and off by these various different tumors. And by sort of mapping, if you would, trying to figure out how all these genes are all interconnected, they're trying to figure out what are the common sort of what we call drivers of these tumors. What are the most important things that make these tumors grow, make them proliferate, make them metastasize to various different areas, and make it more difficult to treat. And so once we can identify those various different, the most important targets, if you would, we can hopefully figure out actually how, in fact, to treat these patients better by targeting those specific drivers.
Darrell, I'd like to, I know that you and colleagues are working on the hepatoblastoma, or children with liver cancers, and we have some particular expertise at our institution and Children's Hospital in that area as well. Do you please share that with us?
So my interest, both in the lab and actually clinically as well, is childhood liver tumors, and the most common one is hepatoblastoma. And we're very, very fortunate here to have actually a liver team composed of Drs. Reeder, Martinez, and Novachinsky, who work alongside some of the best liver surgeons in the world, Drs. Cato and Imand in the Department of Surgery. And together we work actually very closely together to take care of the children who have liver cancers. And so it's a very, in some ways, unique program that we work sort of very much hand in hand for those patients who need their tumors resected, for the patients who unfortunately may need to get a liver transplant, and we work together to figure out how to do the chemotherapy and how to do the surgery.
Presently, our cure rates for children are quite high. As Julia mentioned, almost 75–80% of children and adolescents today, regardless of their diagnosis, can be cured of their cancer. So we've developed a program for survivors of childhood cancer, which 15–20 years ago really wasn't necessary, because the explosion and the improvement in outcome is relatively, within the last decade, relatively new. So there really has to be an emphasis on dealing with children who survive cancer, not only to monitor for the effects of the cancer itself and the chemotherapy, but also to return them to a healthy, normal lifestyle. And our program for survivor wellness just does just that. Julie, I'd like to come back for a minute to the Phase 1 program. We are only one program of 20 or 21 in the United States. Who sponsors this program?
So this program is sponsored by the National Cancer Institute, the NCI. It operates through the Children's Oncology Group. We are the only COG, Children's Oncology Group, Phase 1 consortium member in the New York, New Jersey, Connecticut tri-state area. And so we really are the only ones who have access to these trials. In addition, the other consortium that we work with operate out of California, and again, we are the only institution in this area to offer these trials. So it really, again, the idea of our program is to bring options to children in the metropolitan area that might not otherwise be available without traveling long distances.
Mm-hmm. The staff, faculty, nurses, administrative people that we have in our division, in our Herbert Irving division of child and adolescent oncology, make our program a very unique and collegial atmosphere to work. But I think it's also important to recognize that we are part of a much larger community. Our New York-Presbyterian Hospital is one of the top academic hospitals in the United States. Our Morgan Stanley Children's Hospital is a top 10 rated children's hospital, and we are really the only children's hospital in New York City that has such breadth and depth in its cancer program, with all of the other attributes of our children's hospitals, such as intensive care unit, specialized surgeons, etc. But our Columbia University College of Physicians and Surgeons is also a phenomenal medical school and a top 10 rated university program. So I think all of these components together must make this a very unique environment for all of us to work, and I think it allows the patients that we care for the ability to tap on any number of wide resources that might be available to help them and to cure them.